All right. Welcome to today's webinar. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. Today we're going to hear about telepharmacy from Greg James and Adam Chesler. Go ahead and take it away, guys.
Thanks, Becky. I'm going to kick it off here, and then I'll let Adam jump in. We decided to not force you to listen to either of us for an extended amount of time. So hopefully it'll be good, a little bit back and forth. But just want to thank Becky for inviting us back here to the Telos Resource Center webinar series. We really appreciate them and appreciate the collaboration we've had with them over the years. It's been fun to see how both organizations have continued to grow and develop. So we're excited to bring you guys an update on what's been happening with telepharmacy. I invited Adam, who he'll chime in and introduce himself here. But just to kick things off, I'm Greg James. I've been working with Telepharm and in telepharmacy now for about 4 years. So before this, I didn't really know that much about telepharmacy or pharmacy in general. But really excited to see some of the developments we've had in telepharmacy here in the past couple of years in particular. Adam, you want to introduce yourself?
Sure, and I'm Adam Chesler. I'm the Director of Regulatory Affairs with Cardinal, and I've been doing telepharmacy for about 3 years, and I think kind of the same as Greg. I'm a pharmacist. I had operations experience. I did regulatory affairs experience with PTCB for a while, and I was just surprised to learn how much telepharmacy was really going on once you start digging into it and how it's not really a new concept. It's been performed safely for a while, and we'll get really into detail about that, but we'll let Greg kick it off.
Cool, thanks, Adam. So just really quick disclosure here up front, just so that everybody's aware that Telepharm was acquired by Cardinal Health, and we do have a commercial interest in telepharmacy, but we try to keep all that out of all of our presentations. It's purely for educational purposes. You know, if you have any questions, we're always happy to be a resource and dive into more details, but just want to get that out of the way. I know Adam's favorite thing to do here at the beginning is always to say what telepharmacy is not, and telepharmacy is not online pharmacy. It's not a way to just go online and get your prescriptions. That's a pretty common misconception. So we'd like to start out here at the beginning and run through a few kind of overview slides that I'll walk you through, just so that we're on the same page with telepharmacy. And we always like to repeat this over and over, because if you've never been to a telepharmacy, you've never seen one in action, I think it can be a little bit confusing. And telepharmacy is a little bit of a blanket term as well, that refers to a lot of different things. So that's what we wanted to show here on this slide, is that there are two major types of telepharmacy, one on the inpatient side and one on the outpatient side. And so those include, on the inpatient, is remote order entry review, and IV admixture type telepharmacies. On the outpatient side, we have the remote dispensing and remote counseling, which both of which are a part of what we're going to discuss today. The workflow for a remote dispensing telepharmacy is that the pharmacist is located at a remote pharmacy. So a prescription, patient would come in with a prescription or have a prescription sent over electronically to the telepharmacy location. In this diagram, it's location A. At that point, the technician would fill that prescription. They have an inventory on site, so they would fill that prescription and they would take images of it as they're filling it, and then it sends over to the pharmacist at pharmacy B for the verification, drug interaction, drug utilization review, all those things, to make sure that it's a safe dispense. Then when that patient is ready to pick up the prescription at the telepharmacy location, site A, the technician will help the pharmacist, or the patient, connect to the pharmacist with a live video call, and that way the pharmacist can answer any questions and counsel the patient on the drugs they're receiving that day. A little bit of the history of how this came to be. It started way back in the day. I know Adam had some anecdotes about back in Australia, and most of the population in Australia, if you're not aware, lives on the coasts, and so there's a lot of rural areas, very, very rural backwoods areas in Australia, and there are some documented cases of how they were using it, flying out with the doctors would fly out with a chest full of medicine, and they would call the pharmacist and bring them in that way. But really, it got its modern day start in North Dakota. North Dakota is the first state to pass rules and regulations surrounding telepharmacy, and they kicked off a study in 2002-2003 timeframe that ran for about 6 or 7 years, and they ended up having 81 or 83 telepharmacies involved with that study. It was a federally funded study, and the conclusion from that is that it was a viable solution to bring these types of services to patients in need, but we hadn't yet reached a point where it was really commercially viable, where the technology, advances in technology and broadband access and all these things had gotten to a point where we were actually able to commercialize this and take it out to market. And that's really where we got to in the 2012 timeframe, is when all of these factors came together and really created an environment that was able to provide these types of services in an efficient manner to patients, and a more widespread manner as well. And this is the Leaky Bucket, and it's based on IMS Health data. And I really like Adam. Adam, as a pharmacist, he really likes to tell the story. So I'll let him talk about this slide.
Thanks, Greg. Yeah, I really like this slide. Just thinking of it as a pharmacist, out of every 100 prescriptions, 50 to 70 of them arrive at a pharmacy. They say 48 to 66 are picked up, 25 to 30 taken properly, and then 15 to 20 are refilled as prescribed. And as pharmacists, it's kind of shocking to realize that only 15 to 20% of all prescriptions are refilled as prescribed. And as pharmacy operators, we look at it backwards and say, hey, how can we solve this problem? How do we make sure patients refill their prescriptions as prescribed? Well, we text them, we call them. I think there's tons of stuff based around adherence and making sure patients are picking up their medications. How do we make sure they're taken properly? We counsel. It's basically what we do. That's our main job. We educate the patients on the medications, let them know that the right way to take it, the interactions. How do we make sure they're picked up by the patient? Same thing. You text them, you call them, you page them over the intercom if you need to. A lot of stuff. Try and get it out in under 15 minutes to make sure they're able to get it. But the big one that sticks out is how do we make sure that they arrive at the pharmacy? And if you think that 30 to 50% of all patients never even show up at a pharmacy, there's nothing we can do to really change that other than make a pharmacist more accessible.
And that's I think where we come in with telepharmacy. We look at this as the ability to really bring that pharmacy access and that pharmacist access to patients in a lot of different areas all over. And there's more and more applications for this all the time as the industry continues to grow and evolve. The traditional sense was out in a rural area where they have to drive long distances to get to the pharmacy. But as we've gotten further into this over the past few years and really understanding the need and the marketplace, we've seen a lot more needs in urban areas where patients may not have readily available access to a car. They might have to take 3 or 4 buses to be able to get to their pharmacy. There's a lot of factors. If they're elderly, it may be hard for them to get around. There's a lot of different factors that play into what does pharmacy access really mean, and that's why we want to work on this, and helping patients to be adherent to their medications is gonna be a major problem right now, and it's going to be a major benefit to patients and patient outcomes in the future. So part of why we get really excited about these things is that some studies have shown that a pharmacist is the most frequently visited healthcare provider by the patients. Looking at some of the numbers, they only see their primary care physician a few times a year. Other healthcare providers, that's specialists and different people that they need to talk to about conditions. They're going to be a few more, but their pharmacists, they see them very, very, very frequently. They're readily available. They're, you can walk in and talk to one at any time. And so the fact that the pharmacist has this close of access to patients is a really important factor. And we think one of the biggest drivers in trying to improve that medication adherence and ultimately improve patient outcomes. And as Adam talked about, how do we get more patients to actually show up to the pharmacy? it's a lot easier if it's convenient. I think this is kind of a no-brainer here. You know, that people want to be able to access their prescriptions in a convenient, easy way. And so, in this statistic is that 95% of patients actually filled their prescriptions when it was offered at the doctor's office. So if a pharmacy is able to operate in that doctor's office and provide those prescriptions right on site, that number, instead of it being 30 to 50% of patients are not filling it, it goes down to 5% of patients are not filling their prescriptions. So we can make these really direct conclusions between pharmacy access and the convenience of it, and the habits of patients and their desire to actually fill their prescriptions and stay adherent. So here's a couple of examples just to show you kind of where things came from and where things are moving. This is one of our earliest telepharmacies. We're really excited about this one. It's still operating today. It's been in operation for almost 4 years now, and it's in a small town in Iowa, in rural Iowa. It's about 650 people there, and it was 24 miles, I believe, to the nearest pharmacy for them to get there. In fact, it was a New Care pharmacy was their closest pharmacy. And that building right next door that you can just see the side of right there, that's actually the Story County Medical Clinic. So that's their local health clinic. And the local health clinic has been there for a long, long time, and they really wanted to get a pharmacy in town to help their clinic. And that's exactly what happened once they discovered telepharmacy and they were able to open this pharmacy in town, is that the clinic saw a boost in their patient base. And the pharmacy has been very, very successful because these two things work in tandem. And so we used to see a lot more of these types of telepharmacies where it's a standalone pharmacy, typically in a rural community. And this is what it would look like. You walk into its own building, and you can see it looks just like a normal pharmacy. It has the drug stock and the drug inventory behind the counter for prescriptions. It's kind of hard to see in this picture, but you can see along the wall on the right side there's some of the over-the-counter non-prescription things that the patients might be interested in that come along with that. And then the area here behind the counter where the technicians are working. And really the only difference that you're going to see is that there's no pharmacist on site in a telepharmacy. Otherwise, you're going to see the same inventory. The technicians are behind the counter working and filling the prescriptions. Everything is going to be pretty much exactly the same. It's just you're going to speak to that pharmacist and with that video screen instead of directly in person. And this is more where we're starting to see things trend. And I wanted to add this in because it's really interesting for us to see that telepharmacies are really starting to take hold in community health centers and federal qualified health centers, where they can provide that service and couple that service together with the clinics and the prescribers and the providers all in one place. It makes it more convenient for the patients. If they do need to travel to go to arrive at this type of facility, they're going to see their doctor or provider, and they're going to be able to pick up the prescriptions and be educated right there on site before they even leave. And at the same time, it's a lot easier for the doctors and the providers to be able to get information about the patients. Are the patients being adherent? Are they picking up their meds? Are they refilling? Things like that. So it just makes a really, really convenient scenario for everybody involved. So with that, I'm going to turn things over to Adam. He's going to walk you through, as the regulatory expert, he's going to walk you through some of the landscape changes both on a national level, and then he'll dive into the specific Upper Midwest Telehealth Resource Center states.
All right. The exciting part, the regulations. I know everybody really loves talking about regulations. But it's interesting if you look at the map in 2008, how many states allowed telepharmacy. As we mentioned, it started in 2002, and this was 2008. And this map is even a little misleading since it's kind of across the board what they allowed. Texas had some really weird rules. They put them in place around 2008. But Illinois had completely open telepharmacy starting in 2008, and I'll get into more detail there since I know that's relevant to the people here. But Utah had and still has this weird rule where you can only do telepharmacy if it's 15 people per square mile in a city, and that rule was written so they could have telepharmacy in one town. And it was pretty sparse back then. But you look at 2018, it's become a much more accepted concept. And as Greg said, 2012 was kind of the turning point for that. The technology really caught up. It wasn't $50,000 to get a camera anymore. It was $10. Broadband was much more prevalent in a lot of areas, and people really saw the benefit and the ability to expand access. And I think another concept that really fueled the growth was the decreasing reimbursement rates. You can't necessarily stay open or have a pharmacy on every corner filling prescriptions anymore. You had to provide additional services, and as independents started to close, they needed to find other ways to stay open and access these towns, and to really increase the spread of telepharmacy regulations. And as a side note, Hawaii, for some reason, their statute expired, so it's no longer legal. It used to be legal. Well, I'm hoping we'll work on fixing that, and I'm happy to travel out to Hawaii to work with them as much as possible. We'll see if that gets approved. Anyways, as we mentioned, the regulations are fragmented really across the board. They're different in numerous places. There's different settings that you can practice telepharmacy in. Can it be in a community setting, just in a hospital setting, or a clinic setting? And that varies wildly by state. As I said, the practice setting. And then there's verification site location. Some states allow you to verify from out of the state. Some of them require you to stay in the state. Illinois, you can verify a prescription from anywhere in the U.S. You don't have to be in the state of Illinois. Iowa, on the other hand, specifically says you must be in Iowa. I guess I'll use states here. Indiana says you must be in Indiana. Urban allowances, a big thing people like to put in there are mileage restrictions. Again, Illinois doesn't have any mileage restriction, and I'll get in more detail about each state, but Illinois doesn't say you have to be X number of miles from the closest pharmacy. If you can get Walgreens to rent you space on their roof, you can open a telepharmacy on the roof of a Walgreens. They really don't have anything in place for that, whereas states like Indiana, if you're in a hospital or a clinic, there's no restrictions, but if you're in a community model, there's a 10-mile distance from the closest pharmacy. States that have telepharmacy language, we think could benefit from aligning their rules. It's very confusing as people go state to state because it's very different state to state. I think the concept of telepharmacy has proven to be safe, so we would assume it can be practiced the same across all states, but I do understand every state is different. NABP has created model language. They saw that this is continuing to increase, and they're starting to get involved as well. Each regulation also has little weird caveats in it, such as things like pharmacy technician certification, or how many hours or years of experience does a technician have to have. Some states say a technician, it's up to the pharmacist. They can really decide who since it's a delegated authority, and that's kind of you'll hear this coming up a lot in pharmacy lately, is what can a pharmacist delegate to a pharmacy technician? Look at states like Idaho, they're allowing a pharmacist to delegate immunization authority, which some people agree with and some don't, but it's giving the pharmacist the ability to delegate it. They're not telling them they have to. And some states believe that the pharmacist has the ability to delegate to a technician if they can work in a telepharmacy. They're not forcing them to, so it's ultimately the pharmacist's license, and the pharmacist needs to decide. Whereas other states like to put regulations in place to help guide that. They don't necessarily trust their pharmacists, and they would say a technician needs 1,000 hours or needs to be in practice for a year before they can work in a telepharmacy. Some states limit the number of remote sites that a pharmacist can oversee. Illinois says you can oversee 3 telepharmacies. Indiana says 1 telepharmacy. Some states don't have any limits. Like Iowa says whatever you're, as a professional, assume you can do. The number of sites you feel you can oversee safely, since every step of the pharmacist check is still in place. They think it's the only difference is you're supervising the technician from a remote location. Nothing is changing on the pharmacist role. They're still in every step of that process. That the volume will limit them. And some states have technician ratios, and that would limit you as well. How many technicians can you oversee? And if you have to abide by that ratio, because the concept of operating the pharmacy, again, is the same. It's just doing it from a remote distance. Some states are putting in rules around controlled substances. I know opioids is a huge topic right now on every state. So can you have C2s in these facilities? Can you have any controlled substances at all? Some states, especially the ones that look at this for a rural concept, need to have some controls. If you're out on your farm and you get hurt and you go to the urgent care center and they give you a prescription, then you can go to your pharmacy and get an antibiotic, but that's it. You can't get any pain meds. And I know a lot of the people who work on farms are tough, but I don't think they should be denied that ability. Some of them require you to bolt all the controlled substances into a safe that's locked to the floor. Some of them require you to count them on a perpetual basis. So a lot of states are looking at different rules around controlled substances in these facilities. Again, we talked about mileage restrictions. I think that's an interesting topic. Security requirements. What kind of security do you have to have in place? Is there a panic button? Most telepharmacies have full camera coverage of the whole facility. So you'll hear all the time, is it safe to have one of these pharmacies without a pharmacist on site? And I think I even talk about that later in here, but I think if someone's going to rob a pharmacy, they're going to rob a pharmacy whether a pharmacist is there or not. But if you're going to pick a pharmacy to rob, one with full HD video coverage of the facility, so a pharmacist can supervise their technician at all times, is probably not the best choice, especially since most of them require 30 to 60 days of retention of that video. Technology requirements, HIPAA security, software needs to be HIPAA secure. There need to be things in place to make sure it's private. What happens if the technology fails? What happens with the telepharmacy? It closes to the public just like a traditional pharmacy would. And then signage in the telepharmacy location. I listed all these just to kind of show you how much the states differ and little things they look at. I can't even begin to express how much time I've spent on what a sign in the telepharmacy needs to say, whether it says a pharmacist is overseeing the facility from a remote location or a pharmacist will be, and it's just a sign to present to the public that says a pharmacist is overseeing the location, but they love to regulate that down to the T. We'll get a little more specific with your guys' states. If we start talking about the need for telepharmacy, look at Illinois, Indiana, Ohio, Michigan. They all have pharmacy deserts, which is 10 or more miles without access to a pharmacy. And I think even the concept of pharmacy desert we can discuss here, because I know University of Illinois Chicago says if you're in a urban area and you have low vehicle ownership, it can be half a mile to a mile. That's considered a hardship. But for the sake of this slide here, we'll refer to pharmacy deserts as 10 miles to the closest pharmacy. There were 89 in Illinois back in, I don't remember what year this was. Greg could probably chime in, but I know that number's been decreasing since telepharmacies have been increasing quite significantly in the state. But look at the patient lives that this affects. There were 107,000 residents in Illinois that were over 10 miles from a pharmacy. Indiana, there's 56,000 residents. Ohio, 34,000. Almost 200,000 residents in these 4 states alone that are more than 10 miles from access to a pharmacy. And I'm sure you all can, I'm down in Dallas, Texas, so we don't have it nearly as bad, but I'm sure you can all attest that in the middle of the winter, driving 10 miles in a rural area is quite an issue if there's a significant amount of snow on the ground. But I don't think the snow cares if you're out of your prescription or not. And then we also have communities at risk, and these are towns that only have one pharmacy. And with the current trend of independent pharmacies closing, these are towns that could end up having issues as well, as large retailers come in and buy independents and close them and transfer their records. And it's just a disturbing trend that's going on. We also like to put in primary care shortage areas in here. When we think about access to pharmacists and how pharmacists are the #1 healthcare provider that patients see, we get asked questions all the time about interactions, medications. If you look at towns that don't have any healthcare provider, the patient's usually going into the grocery store to buy their Sudafed, or not their Sudafed, they can't, but to buy their cold medication or aspirin, and who knows, they don't have anyone to ask if it's interacting with their warfarin, that old story. There's obviously a lot of primary care shortage areas in these towns as well. So specifically, Illinois, it's allowed. Illinois is probably the model state we use for all other states. They passed laws in 2010. There really are barely any regulations around Illinois. I kind of really like their statute because their statute says the board can have rules around telepharmacy, and it's a real open statute that allows telepharmacy and allowed the board to draft it. There's over 30 telepharmacies in operation today. It's expanding quite rapidly. As I mentioned, you can open it anywhere. We're seeing telepharmacies opening quite significantly on the south side of Chicago, where there were patients who had access issues and they had to take 2 buses to get to the pharmacy. Behavioral health issues, that it's much more significant if you can have it in the clinic and let patients get their prescriptions on their way out. HIV clinics, #1 indicator of outcome for therapy for HIV is taking your medication. And how do you make sure the patients are adherent when you give them a prescription and say, hey, go fill this? Can't always ensure that they're filling it, can't always ensure they're getting a proper consultation. It's a disease with a stigma. I'm very passionate about, I used to work at an HIV Center of Excellence, so I won't dwell too much on that, but I'm interested in that practice, and I think this is a perfect application for it. But here's some examples of telepharmacies in Illinois. As Greg previously mentioned, they look like a traditional pharmacy. You wouldn't know the difference other than the sign that says the pharmacist is supervising you remotely, and that's really it. The pharmacist is still checking your prescription when you drop it off. They're still checking every step of the fill. They're still counseling every patient when they come in. A patient can walk into a telepharmacy at any time and actually talk to the pharmacist. If they have a question, they can just touch the screen, pick up the phone, and chat with them. You can even see this one in Atwood, Illinois, has a pharmacy drive-through, and they can talk to the pharmacist there through the drive-through on a tablet. It's pretty exciting that we're improving access to patients through telepharmacy. Indiana. So Indiana actually has a law that allows telepharmacy. We worked on that last year. It was House Bill 1540. The governor signed it April 26, 2017. They've been working on regulations for well over a year, though. We're anticipating it to end in April or May. I was told this week the application is going to be up online. Still haven't seen it posted yet, but I was told by the end of the week we should see the application. So we're pretty excited for that. There's a lot of people, a lot of areas in Indiana that are very excited about telepharmacy. They have been for over a year. We thought it would move a little bit faster, but we're excited that it's going to be there. As I mentioned, there's a 10-mile restriction for community pharmacy and no mileage restriction for hospitals or clinics. So if you put it in an HIV clinic or you put it in an urgent care clinic to provide 24-hour access, that you could have that in the middle of downtown anywhere. And interestingly enough, there's House Bill 1382, which just passed this year on March 13th, and it was studying pharmacy deserts. And there's all this talk about pharmacy deserts and pharmacy access. And the bill actually passed to put together a task force to look at pharmacy deserts and see how we can fix that. And they're forming a study committee. It just passed. I highly recommend if you're in Indiana and you're involved, get involved in that study. Let them know. Let them hear from actual practicing people in the area or rural area, people who are concerned with pharmacy deserts and want to affect the change there. That's our kind of recommendation out there. Is if you're in Indiana, reach out to your legislator, get on that committee and help. Hopefully it doesn't take another year or so to get something done out of that, but we all know how politics can be. Now the not so fun states, Michigan. There's no current laws in Michigan. It needs statutory and regulatory approval. We'll kind of, a couple slides from now, walk through what that looks like. We've looked at Michigan and trying to gauge the acceptance of telepharmacy in the state. I think there are a lot of rural issues in Michigan, and I think it would be very, very beneficial. I think there's a lot of politics at play in Michigan, but the board needs approval through statute, so there has to be a legislative session that allows them to start drafting rules. But Michigan is definitely an area that we think there's a lot of need. I think if you're in one of those areas and you're expressing interest, please let us know. Please let your legislator know. Please let the board know. We're happy to keep you posted as things start to turn. But when we're doing legislation in states, it's very hard to come in as someone from an outside of the state and say, hey, your state needs this. They really want to hear people inside the state tell them that they need it. And I think that makes a big difference. So we highly recommend you let people know that you're interested. I think there may not be awareness that it's a desire in the state, and just need that support from local people. Ohio also, even though Cardinal Health is based in Ohio, there's no current laws around telepharmacy in Ohio. We're still engaging with stakeholders. We've had some concerns with the Pharmacy Association. I think they're really looking at pharmacy as kind of the old way of practicing, not really looking at it as a new way of expanding access. But we're trying to help educate them and help them understand the benefit telepharmacy can have and how it can help their pharmacists expand their reach and take care of citizens and residents of the state. So we're currently engaging with stakeholders. They allow remote order entry in the state. So they have those pickup machines where you can enter the prescription, and Cleveland Clinic has it where you can go pick up your prescription out of a kiosk. But there's still no telepharmacy allowed. So that consultation piece and all that other stuff still is not, from a remote pharmacist supervision, is not allowed. Again, same slide that we had before. We just put Ohio up top. If you're in the state, if you see the need for it, please let us know. Please let your legislator know. Please let the Board of Pharmacy know. I think the more they hear about the areas that need this, the more likely they are to undertake the process. Moving forward, how do you implement regulations in states? This is kind of stuff I knew nothing about until I started getting into legislative and regulatory affairs, so I thought it would be interesting to share it. Again, we need statutory authority, so it means the legislature has to say that the board can draft rules. If there's no statutory authority, we have to go to the legislature and get that done. That's a whole other process involving lobbyists and a lot of money and a lot of time and a lot of people's opinions. But once we get that statutory approval, the Board of Pharmacy can draft. They usually have a committee that drafts rules. The board will notice the rules to the public, which allows the public to give comments and kind of chime in on how they think the rules look, how they'll affect them. Then there's that administrative rules review process and approval, and then it's implemented. And that process can usually take, depends on how often the board meets. If they meet every 3 months, it can take almost a year to implement regulations, as seen in Indiana, even though Indiana board meets every month. I'm not going to express my opinions on that, but you can see it's a long process, but it does give a lot of opportunity to get involved through that rule drafting process and make sure that it works for your state. We always recommend looking at what other states have for regulation. I think a lot of now that we're at 22 states since Arizona just passed their bill, we're almost at that more than halfway point. The other states have already done a lot of this work. You don't need to do too much work about regulations anymore. They've all thought about it. They've all been practicing for a long time with telepharmacy. So look what other states have. We highly recommend visiting a retail telepharmacy. Seeing how these are operating makes a big difference. Even for me, when I first heard about telepharmacy, I thought, oh, this is the end of pharmacy. But it wasn't until I walked into a pharmacy and saw that all the checks are still in place and I feel like this is such a cheesy story, but I like telling it anyways. When we've opened telepharmacies, I've literally had people crying because they had no idea how they were going to take care of their mother, who they were watching at home, and then go pick up their prescriptions, and how it just becomes such a hardship for them that they lost their pharmacy in their town. They didn't know what they were doing. Just the amount of time and life that they were able to get back by having a telepharmacy in their town. And it's been touching. It really has meant a lot and kind of helped me with my job satisfaction. Understand the landscape in your state. There's a lot of different players and different opinions at play here. There may be some people who don't like technology and don't want to embrace it and they're scared of it. Each state is different. It's kind of what we're putting in there. So just understand how to navigate that, understand who to kind of talk to. And I always recommend ensuring statutes leave room for administrative rules. We never know what technology is going to do, how it's going to change, how things are coming and changing. And if a statute, which, as we mentioned, is much harder and much more expensive to try to get changed, is in place, and something changes that allows for a better way we can provide access to care, it's easier if the statute gives room to just change the rules at the board level than it is to have to go to the legislature and get that changed. So we always recommend leaving room for the Board of Pharmacy to kind of update that. Again, some more technical requirements, HIPAA compliance. It's always important to have record keeping, and that's record keeping of what the pharmacist verifies. So initials of all step of the process. Interestingly enough, there's images of all bills, so you can recall that at any time. I think we keep them for 9 years, but the way data and storage has gone, you can almost keep them infinitely now. Consultations, this is an interesting topic that comes up quite a bit, is obviously nobody wants their conversation recorded, but you can have the length of time it was recorded. And if the Board of Pharmacy ever says there was an issue with a consultation or anything like that, they can actually see how long the patient was talked to. If pharmacists start getting reimbursed for consultations, you can actually have a set time that the consultation occurred that you can submit to insurance companies. So it's become a more interesting topic. Dispensing as well. When was it dispensed? Time stamps, data stamps, everything like that. Video records. We've had things come up with size of monitors. People are scared. People are going to try and do telepharmacy through a cell phone, and whether one of these days you'll be able to talk to your pharmacist on your phone, I'm sure that day is coming. I don't think that's really telepharmacy, but I think there will be an ability to have a consultation over your phone. But they have what size monitor needs to be there in order to do a consultation. Privacy, we talked about how it needs to be a private conversation being on the phone. Downtime, what happens during downtime. I feel like I'm being a little redundant in considerations for statute versus regulation. I probably went off topic earlier and elaborated a little more, and we should have saved it for this slide, but that happens. Same kind of concept here, open it up to allow for waivers. So just put the NABP Model Practice Act language up here. I figured you guys can read it real fast, and then I'll give you a test on it, because I know you wanted to go through it. I'm kidding about that as well. But kind of it's all we really had for today. I know it was not too in depth. I'm happy to answer any questions you guys have about the regulatory or about the operations or process. And I know Greg's happy to jump in as well.
Thanks, guys. That was a really thorough overview. So I want to go ahead and open it up for questions. You can use the Q&A down at the bottom window to ask questions. Also, I'm going to queue up a survey. Since the Upper Midwest Telehealth Resource Center is a federally funded program, we always have to do reporting back to our funder, and they ask us to give them information about our activities. So this just is a few short questions, and I do encourage you to go ahead and answer that survey before you log off for today. So let's see if we've got any questions. None yet. So I'll start with my questions. I was involved last year in Indiana with the bill that went through last year. And if you've never been involved in that type of thing, it's a very interesting process to watch it go back and forth. I know a couple other people that were involved as well. And it's interesting to see the evolution of the language in a particular bill. How long did it take to get that law on the books in Indiana?
Well, it's still not done.
Well, okay. So yeah,
I know we still have the law. Yes, the law was done, and it was we had to start kind of working on that about a year before it happened. We started reaching out to the Indiana Pharmacy Association to see what kind of support they had for it. And they actually decided they wanted to carry it on their own. So we kind of stepped in as the support process there, but it was a lot of education. There were a lot of players that came to the table. Everybody has a little tidbit of something they want to add. So it was multiple months until we finally got it through. And so I'd say it was about a 1.5 year process to try to get it through. And we were lucky to get it through the first year.
Mm-hmm. What can you go back to the slide about what the whole nation looks like now as far as allowing telepharmacy? And then off the top of your head, Adam, from a legislative aspect, what states are really come to mind as having some of the worst pharmacy deserts?
Whew. That's a great question.
I can tell you that the Midwest seems to be a sweet spot with both combining the amount of population that we have. Because if you get out in the West, some of these like Montana, there's not any pharmacies around, but there's also not any people around. It's just really, really rural areas. In the Midwest, so throughout, like Illinois is kind of the epicenter, but then, I think everywhere around it. So a lot of the states that are included here in your area, so Indiana, Ohio, Michigan, Kentucky, Indiana, and then Missouri, Iowa, Minnesota, Wisconsin. That's typically where we see the largest concentration of rural population. But as we move towards this new definition of pharmacy deserts, I know that they're looking. Right now, there's some research being done on the top 30 metropolitan areas across the U.S. All the communities or all the cities that are bigger than 500,000 people, and they've done the research and they're working on getting that published as far as where are these pharmacy deserts located. Because in a city like Chicago, they'll say the research has shown that there's over 1 million residents living within the city area that have hardships getting to access their prescriptions. So I'd say even though the need, we see a lot of people focusing out west in the rural areas because typically there's just longer distances. I think probably the largest need is right here, right in the Midwest. And what was the other part of the question? Sorry.
Which state, well, yeah, I think you answered the question. Yeah, which state has the highest number of pharmacy deserts, basically?
It was Illinois for a long time, but that number is coming down now. So
yeah.
The other thing I'll mention about Indiana. Sorry, I'm going to change the topic really quick, but I just looked at my calendar, and we had a pharmacy approach us in 2015 there in Indiana, who was interested in exploring this for a small community. And we started working on our project, working together with the local interested parties. And it wasn't until January of 2016 that we actually went and started presenting to the Board of Pharmacy to talk about this. So just to give you guys an idea of the timeline of what happened here or there in Indiana is, we started having the discussions in 2015, and it took through 2017 to get the laws done, and now through 2018 to get the regulations in place to allow for it.
Right. So the American Telemedicine Association is having its annual conference this year in Chicago. I was curious if Cardinal Health was going to be there, if either of the two of you guys were planning to be there.
We will be. We are speaking at the American Telehealth Association, so looking forward to that opportunity.
Very good. You and what, 40,000 of your closest friends, something like that? Not quite that many. That's HIMSS. So, all right.
That's coming up like next. Is it next month?
Yeah, it's
pretty
the end
soon,
of April, beginning of May.
Yeah. I'm hoping. I'm sure we'll see you there, Becky. But I'm hoping we'll see some other folks that are here not only today, but also that are in your network. That are going to get this recording afterwards, because it's always great to connect with other people who are interested in promoting this idea of providing access through technology.
Yep. All right. Well, it doesn't look like there's any other questions. So guys, thank you so much for your time today. I appreciate the updates, and we'll see you soon.
Thank you.